When you apply this same concept to how to manage a patient with relapsed and refractory myeloma, the question of sequence really depends on what are they refractory to. Are they refractory to just len? Are they refractory to len and dara? Are they refractory to a proteasome inhibitor and len and maybe dara in some cases, as with a high-risk patient? And then you go through what's available and think through it. And so combinations of carfilzomib with an anti-CD38 or pomalidomide with an anti-CD38, or even carfilzomib and pomalidomide together, if a patient is already resistant to an anti-CD38, really do represent reasonable, sort of what I would call standard approaches. But I think with the availability of KarMMa-3 and CARTITUDE-4, the use of CAR T cells earlier in the relapse setting certainly does become an important and exciting option. I think it's one that you need to sit down and really discuss with a patient in terms of risks and benefits of standard therapies versus a CAR T cell. We know in phase 3 trials that the PFS is better for a CAR. And so I think, but it's not a zero risk proposition. And so I think having that discussion with a patient, particularly a standard risk patient, telling them what the relative progression-free survivals could be, is certainly how I approach sequencing of these treatments in the context of early relapse of multiple myeloma.